ACC.11 and the I2 Summit is running at full speed as thousands of attendees gather here in the Ernest N. Morial Convention Center in New Orleans. Welcome to the CardioSource Video News. I'm Dr. Randy Martin. Now, there's still a lot of buzz about the findings of the most anticipated trial of the ACC.11 and the I2 Summit, the PARTNER trial. There were two presentations. The first dealt with a randomized trial that compared transcatheter aortic valve implantation to surgical aortic valve replacement in high-risk patients with severe aortic stenosis. And there was also a second part of that trial that really looked at the Part B cohort, looked at the cost effectiveness, and we'll get back to that in a second. So here to discuss these trials, first Dr. Peter Block. Peter is Professor of Medicine and the Director of the Structural Heart Program at Emory University Hospital in Atlanta. Dr. Athena Pappas. Athena is the Associate Professor of Medicine at the Brown Medical School and the Rhode Island Hospital. And rounding out our group, and we're glad to welcome him, is Dr. Paul Douglas. Paul is Chief of the Division of Cardiology at the Atlanta Medical Center. So we're glad to have all of you here. And Athena and Paul, I've talked to Peter ad nauseum, it seems, about your views on the PARTNER.
What is this?
So let's get a new input on this.
Right.
Seriously, what do you, Athena? What's your take on the PARTNER?
Well, I think there's no doubt that it's incredibly exciting at the meeting. It's a game changer, but a lot of the concerns are these are very experienced, skilled surgeons, interventionalists, imagers. What's going to happen when this gets expanded outward? Should everybody be doing this? What's the learning curve? We should know what our own surgeons and interventionalists do. So,
Paul?
No, you're absolutely right, Athena. And the question is this applicable to the community?
Right, okay.
And if you look at the trial and the way it's presented and the number of studies that were done, it was really a very small number of very specialized, capable centers that actually did the trial. And so the question that I have is this ready for prime time? Is this a therapy that's going to be able to be performed safely and effectively at a community level? And if we don't do it at a community level, are we going to be compromising access to something that's very important?
Interesting points. Peter, what do you think? I mean,
Well,
that's a good take on them.
I think it's an interesting take. The problem, Paul, is that in Europe, that's exactly what's happening. In Europe, any cardiologist, probably overstated a bit, but interventional cardiologists are sort of lining up to do this. My concern about it is that if an interventional cardiologist does 5 of these a year, that probably is not the right thing to do. And if you end up having a center that does 55 or 155 a year, that's probably better for patient care. In the United States, I don't know how this is going to work out, but in Europe, it is working out that people are just doing this, and it is out in the community. And the problem is we really don't know the outcomes yet.
Right.
So we'll see. But 20,000 patients have been treated in Europe. Yeah, don't forget that.
This is really, it sounds like mitral valve repair. You know, it's the same thing where there are surgeons doing 5 mitral valve repairs versus somebody doing 100. What's the deal? I'm sorry, I interrupted you.
no, not at all. I think it's the same historically and in a lot of other arenas, whether it's adult congenital heart disease, hypertrophic myopathy. Should we have some subspecialized areas of expertise? And we know that low volume centers or low volume interventionalists, surgeons, imagers for that matter, might not be the place to be.
You know, Paul,
Well, the learning curve should not be terribly steep. I mean, for an interventional cardiologist,
Right.
I would think that the learning curve shouldn't be terribly steep. And I think back to my days in training when we first got steerable guide wires, which most people don't think anything about. Andreas Grunzig wouldn't allow anyone else to touch that guide wire because it was the latest and greatest, and no one else had the skill set to use the steerable guide wire. And so I'm hoping that we'll be able to develop those same types of skills to make this more available.
You know, Paul,
to a broader
I'll tell you
community.
something. The next generation devices are going to be smaller, right? And the generation of that, after that's going to be even smaller. So I think more user-friendly devices are going to make this easier for all of us.
Right.
And I think also safer for the patient. This is such a moving target that I think to sit here and to sort of hypothesize about where we're going to go is going to be very tricky to do, and we'll just have to see how it evolves. I think the evolution is going to be rapid, and within 2 years, we'll look back at ourselves and say, how could we have said that? This is really silly.
That's what we always say about
Yeah,
it.
that's
That's said 2 years ago, but you know. But I mean, Peter talked about cost too, the cost analysis. I mean, does the cost bother you, or the cost of this, or is it cost in favor of having this therapy?
I think on a societal basis, we have to have some concerns about cost. We certainly do. I think the lead speaker today was, a Nobel laureate speaking about global health and where some money should go. So I think on a global level, you do have to have some concern. And I think it's incumbent upon us to have some concerns.
But the cost analysis, in the end, it's no more expensive than what we spend on the other things that we do. And so it's not cost prohibitive. When we're talking about, in the context of the United States anyway,
Right.
and the way we practice cardiology in this country, it's no more expensive than the other things that we do.
What do you think?
Well, I think the cost is the cost, and whether $50,000 is worth a patient year life of good quality, who knows? It's a philosophical issue. But I will tell you that one of the interesting things coming out of Europe now, the data that are now being generated, show that as you get better at all this, and as you understand it better, we will be able to pinpoint those patients who in fact should not be treated with this kind of therapy, right?
Yeah.
And so as we learn more, we will be able to winnow out those patients who we should say, maybe medical therapy isn't so bad. Balloon valvuloplasty isn't so bad. A rare patient, but nevertheless one that should be told, I'm sorry. And this is a hard thing to do when Aunt Sadie has...
You must have said, hold on. We're going to come back. We need to take a break. You said the magic word there. You said balloon valvuloplasty, and she lit up. I know. So we're gonna take a quick break, and then we're going to come back and look at that point and then some other key factors from today's meeting.
You're watching CardioSource video news coverage of ACC.11 and I2 Summit 2011.
Meet Maria, proud grandmother. She complains that her heart beats strangely, and she's just had an aortic valve replaced. Maria wants to be well so she can be with her grandchildren. Follow Maria's journey from admissions to treatment and release from the hospital setting, and then to post-release care, with all the steps along the way aimed at reducing her chance of being readmitted. Experience the hospital-to-home learning destination, Hall D, number 3347, to learn about innovative technologies and solutions aimed at reducing hospital readmissions. Plus, hear from leading experts in the field and learn how they are implementing new processes to reduce readmissions in the H2H theater.
Well, immediately what we noticed is patients telling us that they really preferred the radial approach. When we first started doing this, they came to us expecting that we would be doing this via the femoral approach. They came expecting a prolonged bed rest time. They even warned us. They said, look, I've got a lot of back problems. I'm going to have trouble laying flat. And when we started doing it from the wrist and they were able to get up and ambulate right away, they were really thrilled.
Welcome back. Now, we had an animated discussion about the partner trial, and as we went to break, Peter said the magic words balloon valvuloplasty, and Athena, as Paul said, almost fell off of her chair. What was your reaction to that?
I think it's going to be hard unless we have very good data to say no to elderly patients, and we do have this long list of things that we can use to palliate. And it is palliative.
Yeah, it is palliative to do balloon valvuloplasty. The valve is not necessarily palliative. It really makes you feel better.
Okay.
Balloon valvuloplasty makes you feel better for a very short period of time, but it is a way to take care of somebody in whom you don't want to implant a valve. The question is, if Aunt Sadie gets sick, it's really hard to say no to Aunt Sadie. If Aunt Sadie has an ejection fraction of 20%, should you implant her The problem is every once in a while, somebody with an ejection fraction of 20% really gets better if they get a transcatheter valve.
Well,
It's a hard issue.
And that's the issue, Peter. I mean, do we have enough data to really be able to adequately predict what the long-term outcome is
Right.
going to be for these patients? And I guess we should be using some of our European colleagues' experience to help us in terms of identifying the folks who are most appropriate for this therapy. The question I wanted to ask you, though, is most of our European colleagues deal with fairly homogeneous populations. Is that applicable? Is aortic stenosis irrespective of your ethnicity or race or socioeconomics? Answer that question.
I think
for
the
me.
answer is no. There.
That's the fastest I've ever heard you answer a question. That's fabulous. And thank you, Dr. Block,
No,
for
you're
joining
very
us
welcome.
today. Okay, let's move beyond Parker, although we could sit here for quite a while. Athena, what else in the meeting is sort of either coming up or that you've seen today is exciting?
Well, I think some of the, posters and oral abstracts were really exciting today. A lot of young people with great new ideas in a lot of arenas, in echo, in calcium scoring, in some of the pediatric populations, looking at how to choose which children might be able to do better with a Norwood procedure. So I think some of the new investigator-initiated data is
So
exciting.
don't forget about the posters. There's a
Don't
lot of
forget
good
about the
stuff.
real
Did
science.
any strike your fancy? I mean, weren't you a judge or a moderator at something?
I was. I think that actually that was the best posters that were listed there.
Okay,
And those were
okay.
just some of the
Just
topics.
cool.
I mean, even looking at how athletes' hearts respond on the right side as well as the left side by echo. So I think we're going to have some really new data just coming out of even.
Super. Paul, what?
Well, the one thing that I think that most everyday cardiologists is thinking about is what's going to happen with healthcare reform. And we just had a major talk on healthcare reform. I think that's something that's going to touch every American, and as a result, will probably have some ramification around the world as to how we do things and how we deliver care in our.
What's
in
going to
our
happen with healthcare reform?
There you go. Your guess is good as mine. No. Right.
Yeah, the answer is no. Thank you.
Exactly.
No, I think you're exactly right. Peter, there's some, you've been here with me most of the day, but there have been some interesting stuff going on today and going to be some more trials tomorrow. What about, give me Everest? That's coming
well,
out?
I think looking forward, certainly in valvular heart disease, the Everest 2 trial now has 2 and 3 year data. And the question will be, are those data still holding up? Is the surgical repair of patients that have mitral regurgitation better or not as good or the same as somebody who's had a mitral clip? We now know at 1 year that after the first 90 days, there's really not very much difference in the way the slopes run. Whether that will hold for 2 and 3 years, we'll see. But I anticipate that. I think it'll be great fun to see how that comes out.
Super.
Good.
Athena, any other?
I think the Stitch trial is going to
Right.
have some results. Again, looking at this a lot of surgical information coming out at the meeting.
Well, it's the ischemic cardiomyopathies,
Yeah.
which there's an increasing cohort of those, and whether revascularization or not. Paul, other trials, other things you're looking forward to?
Well, I think that I agree. The Stitch trial is interesting, and the early results were not as encouraging
Promising,
as you would like, but that's going to help us, I think, in terms of our strategy of dealing with these ischemic cardiomyopathies. Hypertrophic cardiomyopathy, talking about where you get the best care for hypertrophic cardiomyopathy, who should deliver that service. I think that's going to be interesting.
Should everybody do that?
That's a question
There we
that
go.
I
We're
think
back.
is
It sounds like we got a
legitimate.
theme
Same
going
thing.
here.
That's right. Should we all be doing that?
Athena, any other things that you're excited about as far as the trials or what's coming up?
Well, I think there's also there's a great international flavor. So there's a lot of international lunches tomorrow.
Right.
I think there's 17. All have different topics, each driven by the individual society. So I think that's exciting.
Okay. Peter, and Paul raised a lot of issues. I mean, we're really talking about advancing science, and yet we're looking at healthcare reform and all of this. If you looked down the road, okay, so you're training interventional fellows and they want to do valves and stuff, where are we going to be 3 to 5 years from now in the era of cost containment, health reform, and how do we match science going forward and sort of outcomes?
I think that's a very tricky issue. The FDA and CMS are going to have to tell us what we're going to do. My guess is, Randy, that we're going to have science ahead of the fact that we can actually get reimbursed for the science that we would like to put onto our patients. Let me give you an example. This percutaneous valve, aortic valve business, if we actually implant that, but CMS says, I'm sorry, I won't reimburse you, that's really going to cut short our ability to care for patients. And I don't know how that's going to work, but my guess is that we will have to deal with CMS in an ongoing way to try and understand how best to spend the healthcare dollar. I mean,
Right,
Paul's
that's what
right.
Paul's right on,
Health reform is on the way, and the healthcare dollar is a healthcare dollar. It's not going to be $1.50, and we're going to have to split the dollar up properly.
Good. So great points. You want to say anything in closing?
Well, no, and I think that I just thought of another trial that they're looking at the combination of simvastatin and ezetimibe, and whether or not that makes a difference in outcomes.
That'd be interesting.
That should be
Good.
an interesting trial to look
Good.
at.
So a lot of interesting stuff. I like your plug of the posters. Very, very good. So thank you all for being with us. You've been a great panel, and I'm Dr. Randy Martin. Thank you for joining us, and be sure to check in tomorrow as we bring you the latest breaking news from ACC11 and the I2 Summit.